Hi, this is Chris Geller, President and CEO of Pinnacle Training Consulting Systems, physical therapist and personal trainer. I'm here with you today again to talk about the shoulder. The last time we talked a little bit more about a couple of conditions. Today I'm here to review some anatomy first. So when I say the anatomy, let's review some of the basics. But before we begin the anatomy, how does the shoulder really move? The flexion occurs first. Second movement is extension of the arm, side raising or abduction, and adduction of the arm. Lastly, the arm goes into external rotation and internal rotation. So those are 6 degrees of movement within the shoulder joint. Again, on the front of the shoulder, we have the anterior deltoid. On the side, in the frontal plane, we have the medial deltoid. The medial deltoid and the supraspinatus is from the supraspinatus fossa to the greater tubercle. The supraspinatus abducts the shoulder from 0 to 15 degrees, and the medial deltoid carries this motion through over 90 degrees, all the way up into 180 degrees. On the back side, we have teres minor and infraspinatus. They do external or perform external rotation. Teres major, which is along more the medial aspect of the the shoulder, does internal rotation of the shoulder. Internal here. So now that we've covered some of the movements of the shoulder, a little bit of the anatomy, I want to talk about a condition I see a lot of as a physical therapist. That is the rotator cuff. The rotator cuff, and actually a tear to the rotator cuff. Going back to the anatomy, one of the main areas of injury is the supraspinatus. Biomechanically, and with the research, it is the weakest of the 4 sits muscles. Sits muscle stands for subscapularis, which is in the front of the shoulder, infraspinatus, teres minor, and supraspinatus. The supraspinatus is commonly torn and injured with falls, pictures, repetitive overloading motion, where the supraspinatus tendon breaks down. It frays. There's microtrauma to the actual tendon, and eventually it just will break. And lastly, postural combined with impingement. The impingement, again, we talked about is this loading or butting heads into the AC joint. If there isn't proper clearance for the humerus to drop down and glide into the colon cavity, this butting will cause friction and fraying on the supraspinatus tendon. So, with a classic rotator cuff repair, typically seen 40 to 55 years of age, what you want to do and remember is, number 1, where does it occur? Find out where the client had their surgery. Number 2, remember your anatomy and biomechanics. Shoulder press exercise is a great exercise for strengthening the medial deltoid and the top of the shoulder. When someone has a rotator cuff repair, compression from that motion will load and further compress and stress the tissue. Upright rows as well will create internal stress of the humerus on the AC, further stressing the graft. Shoulder side raises are also contraindicated to at least 4 months post and should be cleared by the physician and physical therapist they're seeing. Remember, don't ever start a program until you have clearance from the physician, but talk to the physical therapist client. Or I should say, the client's physical therapist. It's important to develop that relationship. What can you do? Well, again, going back to the back of the shoulder, the rhomboids, lower trapezius, are weaker biomechanically. It's been shown in research. It's been studied by Vladimir Janda. It's been studied by other individuals out there repeatedly. So exercises like mid-row, with a cable, a tubing, are really effective. Low trap, 45-degree angle, pulling down with a cable is excellent. You want to watch your technique. You want to avoid putting excessive stress on that joint. Remember the punch, serratus anterior punch is also effective. Don't forget using the cable, doing external rotation, that's away from the body, and internal. That's going to strengthen, external rotation will strengthen infraspinatus and teres minor. Internal rotation will strengthen subscapularis and the pectoral muscle. You want to also keep stretching the posterior capsule gently. Don't force it and have the client do that. As well as stretching the pectoral muscles, because pectoral muscles will typically become taut. Most of the jobs of clients you probably see, and some of my patients, majority are sitting what? Flexed. We're in a flexed position. We're on the metro, we're talking to people. We're always flexed over or bent over. We want to strengthen these weaker muscles on the back of the shoulder, the posterior aspect. So remember that. Just a little heads up. Last but not least, I wouldn't have anyone do any kettlebells. Kettlebells is a great exercise. It requires what? Skilled concentration. It is power-based. It is unsafe. I actually had a patient of mine who's been injured before by lifting a kettlebell and doing that, tearing her supraspinatus. So again, think about the anatomy. Look at the biomechanics of the shoulder and how it moves. Look at your research. I recommend once a week or every 2 weeks, read some research. Keep up with things. You can even contact us here at Pinnacle Training and Consulting Systems. I'd be happy to share more of my thoughts and my expertise in the evidence-based material to help you. I appreciate your time again. I hope this video has made the rotator cuff repair a little bit more easy to understand, most importantly, what to do and what not to do. Thank you again.